And this was a patient we consulted who we felt was a candidate for TAVR, understood the risks and benefits, had supportive family, and wanted to have a TAVR. So these are examples of ageism. Martha Holstein, who's pictured here, wrote on being an old woman, "Old age is not a status we choose to become. It's a status that we inherit simply by the virtue of living, not dying. It is a status that carries with it negative expectations and one that we cannot physically mask, no matter how much we mentally will it away. And it's likely to affect all of us." So our objectives today are to create an awareness for ageism in healthcare. We want you to understand health disparities and social determinants of health while aging and amongst older adults, and learn how age-friendly health system can be a platform, a structure to minimize disparities. So we want to talk a little bit about the population, and all of you probably know this, but this is a graphic that it's dynamic. It's the percent of the population by age on the bottom, and from 1950 to 2050. So 1950s, we had a young population. It was after World War II. Families were having babies, and that became the baby boomers. And the baby boomers now are entering over 65 population. So you see, by 2030, the fastest growing population is going to be the over 80 population. So we're just going to show this again one more time. 1950, we have a young population here in the United States. Baby boomers are getting older, and through the late 1900s and early 2000s, you start seeing that the fastest growing population is going to be over 65 and soon the over 80 population. Okay. All right, I'm going to switch. And as life expectancies have increased, in 1900, a child born was expected to live to about 45 years of age. In 2019, before COVID, life expectancies are much higher, but there are disparities. A Black male, life expectancy is 66. An Asian female, life expectancy is to 85. Overall, life expectancy is about approaching 80 if we take in total. So a near doubling of a lifespan in a century. Just to give you an idea, these are graphics we use. This is New York downstate area. Long Island, we're basically looking at. Manhattan is all the way to the left, the small island. And we've mapped our hospitals in our health system at Northwell with our population. We worked with our strategic planning group to create these maps of population over 65, and it helps us to communicate with our health system leaders. So the darker the color, the higher the percent of the population over 65. And this is helpful. Then this is the percent of our population over 85. Percent of the population over 65 living alone, significant. Percent of the population over 65 not white, and we're seeing the darker areas are in Brooklyn, Queens area, and Bronx. Percent of the population over 65 below poverty, and the percent of our population 65 and over with rent burden. This shows that our older adult population in general is living alone, having rent burden, financially stretched. This is our New York data, 19 million people. Over 65 is 17.5% of our population. Less than 18 is 23. By 2030, that is expected to change. We'll talk about that. White population 54.7%, Black population 14.4%, 19.5% is Hispanic, and 9.1% is Asian. I want to briefly talk about aging physiology. Also, one second, that by 2034, the over 65 population is going to outnumber the under 18 population for the first time in our country. We need to be aware. Aging physiology. Baltimore longitudinal study on aging from the NIA came out with this overall average means of organ reserve. And with age, our cellular water content decreases, our kidney blood flow decreases, our maximum breathing capacity decreases, nerve conduction decreases, and heart output decreases. We know this is aging physiology. We're making great efforts to improve and lessen that decline with age through what we say is healthy aging efforts, preventive health efforts, or maybe as Louisville has, which I love, optimally age. We want to prevent harm to our organs. We want to be safe. We want to promote healthy living, prevent injuries, and that's all part of the age-friendly health system initiative too, to optimally age. So we'll talk about that. We want to decrease the functional, we want to minimize the functional capacity that decreases with age. If you see the top graph, which here we're looking at normal aging, and then the bottom purple graph is accelerated aging. And we know with disparities in health, we can accelerate aging over time. We are trying to decrease or lift up those curves so that people live well, independent for a longer period of time before they hit frailty or disability. So ageism. And I think it's important to understand aging physiology, the differences that we face as we age when we talk about ageism. So ageism is, this is a picture of Robert Butler, who defined this and brought this to attention. And he was the first, the founding director of the National Institutes of Aging. And he was the chair of my Department of Geriatrics when I did fellowship. Ageism is the process of systematic stereotyping or discrimination against people because they are old. Just as racism and sexism accomplish with skin color and gender, ageism allows the younger generations to see older people as different than themselves. Thus, they subtly cease to identify with their elders as human beings. We really want to abolish this. We want everybody to be human beings and introduce and maintain humanistic qualities in healthcare. And then there's societal ageism, as the Ontario Human Rights Commission wrote. It's a tendency to structure society based on an assumption that everyone is young, thereby failing to respond appropriately to the real needs of older persons. We've built society for young people. We need to be aware how these barriers affect us as we age. And ageism is also incorporated into our anti-discrimination trainings that we have in our health system. Harassment or discrimination based on sex, race, color, religion, national origin, age, disability, or any other characteristic protected by federal, state, or local law is unlawful and also violates my employer's policy. This is universal. But caring for individuals over 65 have challenges because it's a very heterogeneous, complex population. There's functional variability, there's medical complexity, socially varied, as we talked about in the population that we are in New York, and this is true everywhere. There's sensory challenges as we age, there's psychosocial variability, the cultural changes, multi-generational support, or maybe aging alone. And there's everyday examples of ageism that we see. You've seen these commercials of insurance company. It's funny, but it's ageist. 90% marketing dollars target people less than 50. 90%. Blaming the healthcare crisis on aging baby boomers. And the fact is, we have some incredibly productive, vocal, active examples of aging optimally that we need to embrace and not blame the healthcare crisis on. Assuming that the population over 65 is technologically incompetent. I've had patients say, old people go there, I don't want to go there. I had a senior moment, right? That's an example of ageism. And then there's benevolent ageism, senior discounts. It just assumes that there's a need. Is it respect or there's assuming a need? But there's benevolent ageism. There are different types of ageism. There are 3 dimensions: how we think about it, cognitive, emotional, how we feel about it, and behavioral is when we act on ageism. And then there's implicit or explicit manifestations of ageism. Micro, how we interpersonally react, how we care for our patients or treat our patients. My interaction with a patient talking to their caregiver is an example. Meso, within social networks, inviting people, excluding people. Macro, through institutional policy or cultural traditions or societal behavior. So micro, meso, macro. Ageism in healthcare, there's provider-based ageism. As I mentioned, the micro interpersonal. There's treatment options. Micro, this can be micro or meso. It's been shown by Dr. Wenger and McLaughlin, cardiologists, that cardiac treatments with age tend to be more medically managed, especially women who are older tend to have more medical management options provided to them rather than surgical or interventional. And lung cancer surgery, similar. Communication, how we communicate, we'll get to that. Screening guidelines are actually policies that are in place that are often age-based, and we have to be cautious of that. And then I want to also mention that there's self-ageism in healthcare. People that really struggle with their aging, they don't want to be old, they seek less care, and they are avoiding, they're fearful. System-wide macro ageism in healthcare, we've seen that over 65 years of age make up 15% of the population, but they account for 36% of healthcare costs. Yet, only 1% of philanthropic money goes to aging. So I want to comment on the Traeger family who has supported this conference, and I salute that. There's lack of aging, geriatric, gerontological training, even in the palliative curriculum, and I have here with my colleague from palliative medicine, there's limited geriatric training in palliative, the palliative curriculum. Is that a form of ageism? In the long-term care world, it's a very limited service, and it's not preventative. It doesn't really help people get to their next planning. Even if they're using subacute rehab, it doesn't help with their next stages. There's minimal participation of over 65 in clinical trials. We're making progress there, but we have to be inclusive. It's difficult to identify ageism. You know, if we call it out, we see it, but sometimes it's hard to see it. And a lot of the quality measures of hospitals and insurance companies are not age-friendly. And I use the example of sepsis. If somebody doesn't want antibiotic treatment, that is not part of their goals of care, they should not be incorporated into some of these quality measures. A lot of the quality measures are not goal concordant measures. So why is there ageism in healthcare? There's fear, terror management theory, fear of aging. It's easy to differentiate people to make us protect ourselves. There's a functional approach theory, meaning efficiencies. Our corporate medicine, productivity minded, it's better to be efficient and give standardization in a very heterogeneous group. So it's easier to homogenize things, make things simple, but we can't because people are, especially over 65, are very different. And there's a value system placing value on youth over age. Young mothers nobler than older person with complex health issues. And ignorance, people just aren't trained. It's not a part of their awareness. So effects of ageism and performing person-centered care is important. It helps bypass ageism. But if we don't perform person-centered care, it can lead to poor diagnosis, underdiagnosing, assuming a pathology is due to age, over-evaluating, not identifying natural aging or aging physiology issues. So it can lead to overuse of tests and procedures at times, so it can cause underdiagnosing or overdiagnosing. Not aligning care with what matters most to a person leads to failed care plans. Poor quality of care, it can lead to harm, complications, longer length of stay, readmissions. And this was an article, Achieving Diagnostic Excellence for Older Patients. And it often leads to poor communication with patients. Communication with over 65 in a varied group can be complicated by cognitive impairments, sensory deficits, functional limitations, not able to get to somebody to a private area to have important conversations, for example. So we know that when communicating with older adults, physicians, clinicians may be less patient, less engaged, less fair or equal, less egalitarian, less responsive to issues raised by the patient. They're more, clinicians, we know this, are more interested in provider-raised topics, more likely to use elder speak, condescending, childlike speak, and more likely to assume that there's a cognitive impairment, like my patient who felt she was spoken to differently when she was in a wheelchair. So tips to combat ageism, and besides our age-friendly health system work, which you'll hear about, is ask about a person's baseline function. Don't make assumptions. Ask, what were they doing a few months prior to their admission, functionally, cognitively. Ask, is there something you would like me to know about you? And I remember asking this even back as a resident, and an older woman with a hip fracture. And she said to me, I was a prima ballerina. I trained in New York City. So this was like, wow, that was eye-opening. I saw her differently. Adopt person-centered, evidence-based treatment approach. Acknowledge the need to eliminate ageism in your practice. Identify ageist attitudes and practices. Actively work to reconstruct ageist attitudes, and define practices and attitudes that are not ageist. Be really conscious of it. And then this is from Ross, how to deal with everyday bias. It's pause. P, pay attention. Pay attention if you see ageism, or be conscious of it. Acknowledge your own assumptions. Understand your perspective. Seek different perspectives, and examine your opinions and make a decision. So pause when you're seeing someone where you may be impatient, doing elder speak, talking to a caregiver, not to the patient. Just pause and use these steps. But we have real challenges moving forward with ageism, and why we need to be conscious about this. There's growth in uniformity in healthcare. Their demands for productivity and efficiency are great. The system is really built for younger, less chronically ill patient population. And we talked briefly about the questionable quality measures and why age-friendly health system incorporating quality measures will be important. And addressing health equity in older adults, because it's a heterogeneous group, it's a growing population, and we have to have health equity. So I'm going to turn it over to Dr. Park, who works at what I mentioned was Forest Hills, which is in Queens, New York, which is an extremely diverse patient population with over 100 and something different dialects and languages. So, and was in the center of COVID, the first surge.
Thank you so much. Good morning, everyone. Next slide. So just like Dr. Carney was saying, that we are aging not only very rapidly, but we're becoming more diverse. And soon, over the next 2 decades, the proportion of older adults in the minority groups will substantially outpace that of non-Hispanic whites. Over 80 million Americans will be 65, and minorities will soon account for 40% of all older adults. So because of this growing number of diverse older adults, we have to consider how we are taking care of our patient in a culturally competent manner. It's more important than ever. So when we think about minority health, this phrase really stood out to me. Minority health determines the health of the nation. And now, although life expectancy has really improved for most Americans, including infant mortality, so many of our minority groups are still experiencing disproportionate burden of preventable disease, death, and disability compared to non-minorities. So what is health disparities? These are preventable differences in the burden of disease, injury, and violence, and in opportunities to achieve optimal health experienced by socially disadvantaged, racial, ethnic, and other population groups. Next slide. So when we talk about ageism, especially in a diverse community like where I am and obviously where you guys are in Louisville, we have to think about racism and what those implications mean when we are treating our minority older adults. And the effects are delayed and foregone care. And this is something that Dr. Carney already mentioned, but if you're in a minority group, there are adverse health outcomes and really increasing morbidity and mortality. We've seen that during the time of COVID, which we'll go into later. So the American Geriatric Society really looked at this in structural racism and ageism, and really put out there the statement of a just healthcare system is one that recognizes that whether groups are based in age, race, and gender, socioeconomic status should not affect the quality of healthcare. And that's something that we believe very strongly in our health system. Next slide. So these are some examples of health disparities in older adults. We wanted to group them and really show how we can understand them. So low health literacy, and that includes health, language, and technology and digital literacy. Lack of caregiver support, and oftentimes our older adults, they have estranged families or many times even have outlived them. Or they're living in an isolated living environment, either in multi-generational homes where a lot of their family members have moved on. And they're even the senior, the NORC, living in place, they're still isolated and they become homebound. There's also healthcare bias and discriminations in the minority groups for years that they have been affected, and it plays into their healthcare. And obviously there is still a need for research in the minority groups in all disease states. So what does this create? Reduced access to care, reduced access to healthy lifestyle options, including nutrition. We see this often in heart failure patients where nutrition is so vital in managing their heart failure. There's lack of trust, like I said before, and oftentimes that leads into communication with healthcare providers due to language, biases, prejudice. And on top of that, in a complex healthcare system, where they have to navigate through that with increasing comorbidities, they fall through the cracks, especially those in the minority groups. And what does that lead? Like I said before, increase in mortality, morbidity, and debility. And often these leads to complications and disease progressions that could be preventable. And also leads to increased use of acute care. In the ED, urgent care, a lot of times, especially in underserved communities and urban settings, primary care is being dealt in the EDs. Increase of readmissions, prolonged hospital stays, and the burden of in the critical care units. So these healthcare costs increase, obviously account for 40 to possibly 50% of healthcare costs in the last years of life. Next slide. So of all the barriers that lead to disparity, the one that is really I wanted to focus on is the provider and patient race and ethnicity discordance. Diversity in healthcare workforce, not just providers, is a really key element for patient-centered care. So for us to be able to address disparities, we need the ability of our healthcare workforce to have cultural competence and diversity. And there is specific need for minority staff, not just within healthcare settings, but out there in the community and to outreach. So that plays into language and culture accordingly. We saw many lessons to be learned during the time of COVID. We saw firsthand what ageism truly was affecting our patients. There was discrimination, especially in triaging and resource use. We saw that firsthand in New York, in the US, but also obviously in Italy when it first hit. So we saw in horror the effects in all those patients who were affected. And these are some of the articles that really describe that. The other areas of disparity and equity was when we were rolling out the vaccines.
A little echo.
Yep. So obviously, the political environment, geographic factors that really created so many challenges to access to vaccines, acceptance. That trust was really fragmented at the beginning of the COVID pandemic, and it really affected our ethnic minority groups, especially in the Black and Hispanic groups. They were less likely to be vaccinated, more likely to get seriously ill. Because of that distrust, it really led to a lot of vaccine hesitancy. There were also disparities into access to care because of language and digital literacy. So many of our language limited patients and caregivers were affected. And these are just that picture of the Javits Center when I brought my older parents and in-laws to the vaccine. I mean, if I wasn't there online trying to get them to be vaccinated and enrolled, they wouldn't have been there. So there were so little people getting vaccines in the first vaccine rollout. Next slide. So what can we do? And Dr. Carney mentioned about, putting processes in place. But, in order to put process in place, we have to also be mindful of talking about our culture, asking our patients and what is their preferred language, and really understanding and assessing for health literacy and asking about their values. We have to continue on becoming skilled effectively and understanding there are social determinants of health that is going to affect our patients.
So I'm just checking the audio. Good? Okay. So Northwell Health, we have been nationally recognized for our age-friendly initiatives by the IHI. They put out this newsletter, they've acknowledged us. And for those of you that don't know, the age-friendly health system incorporates 4 M's. What matters most to a person? Medications for safety, mentation, screening for dementia, delirium, depression, and mobility, making people as independent as possible and as safe. We started our journey to be age-friendly back in 2014 when we had a health system collaborative that was a quality improvement collaborative called the Advanced Illness Collaborative. It was the second system-wide quality improvement collaborative. The first one was for sepsis. The second one was for improving the care for individuals with advanced illness. We had to define what advanced illness meant. And out of that, once we defined and identified patients with advanced illness, we had to have goals of care conversations with them. We had to train our clinicians on how to hold goals of care conversations. We created a goals of care document. And then we started hearing about age-friendly health system, and we changed this collaborative, this quality improvement collaborative, to become the Advanced Illness and Aging Collaborative. And that's the format and platform we use to embrace our age-friendly initiative, which really started in 2019, but formalized during COVID when we saw such the population with COVID, and it really got attention and helped our health system to take action. In 2020, we developed an older adult medication safety task force. The pharmacy was leading. That became a platform for one of our M's medications. We have a joint steering committee for dementia, and that is another platform for the mentation M. And we started focusing on the 4 M's and creating metrics around them last year. So that's a bit of our journey, and I'm going to turn it over now to Dr. Park.
So as we were rolling that out, in order to do the rollout, we had to get leadership buy-in and really help continue on the education and create committees and champions locally on site, as well as getting the system support. And working with different departments and different disciplines, we needed a really great collaboration, like Dr. Carney mentioned, with our nursing and pharmacy partners. And as we're doing that, because you saw on the map, Lower New York, we are so diverse, we have to incorporate awareness of the health disparities. In order to do that, we have to be minded of the concordant care, really enhance our research opportunities on a local and system level. And I'm really happy to say our health system is really taking into part of the social determinants of health. There's a very structured, systematic approach to addressing that in our health system. And understanding access to care is so important. We can do fantastic work and excellent care within our hospitals, but after they leave, how can we continue the care at home? And utilizing and identifying those caregivers, they're a really essential part of the treatment plan. Next slide. So this is the some of the recommended committees within the 4 M's. Just an example of all the efforts that we established and opportunities, not only locally, but on a system level, to really help our sites in the ambulatory and inpatient world to achieve those 4 M's. Next slide.
All right, so I'm going to describe 6 steps to be for our age-friendly health system in Northwell. Our first step was assessing. We assessed everything in our health system, in the research world, education world, clinical programs, initiatives, collaborations we've had that could be labeled in any of the M's that were for older adults. And we just assessed and inventoried everything that we may have that met the 4 M's in order to be recognized and understand the gaps. We were very methodical about it. We looked, if you see on the left side, all of our inpatient programs that may be in these 4 M's, outpatient programs, community-based programs. We mapped it across all of our hospitals, and we just put checks in. Do they have this? Do they not have it? We did post-acute on the left side, telehealth services, education and research, and again, across the health system at all of our hospitals and their communities. And we were very methodical. That assessment led to recognition, and we applied to IHI to have our hospitals and programs recognized. So there are 2 levels for age-friendly recognition. The first level, which is actually level 2, is age-friendly participant. You just participate, you've been recognized, and then committed to care excellence. You have to have data and support. So we show this with our leadership of the hospitals, which hospitals are recognized. Everybody's recognized in some format, and which ones are at the highest level. And Forest Hills, where Dr. Park is at the higher level. Then we also did 64 ambulatory practices, all got recognized, and we showed how they were meeting the 4 M's. We worked with IHI, and we now have a psychiatric hospital, and our skilled nursing facilities are also recognized. Then based on our assessment and where we are at the starting point in recognition, we created a strategic plan. That's our step 3. And as mentioned, we had committees for every M: mentation, mobility, medication, what matters most. And we focus first in the inpatient setting, so we're moving up in the hospital-based, and we'll show how we're doing that. The slides to come. We optimized existing assets. We started and leveraged what we had and explained where we wanted to be. And now we're going to be trying to work in the ambulatory and skilled nursing facility and continuing care space as well. And the goal is that this will enhance patient experience and safety. These are evidence-based tools that we're using by IHI. This is a quality improvement effort. We're starting to see quality improvement with our goals of care conversations, which is what matters most. And it is our hope that we will have the benefits, further benefits, as we move forward on this. So step 4, Dr. Park.
So step 4 is choosing our metrics, because in order to see how we're doing, we wanted to measure ourselves. So some of the measurable metrics we used was goals of care documentation. And like Dr. Carney had mentioned, we developed a structured tool so we can, that's embedded in our EMR system, so we can capture it and measure it through our dashboard. So it was the goals of care documentation. Mentation is the CAM screening for delirium, and that is also something through nursing, and that could be captured through our EMR, and we could incorporate that into our dashboard. For mobility, we do something called, it's a standardized mobility tool scoring assessment that is called AMPAC, and that's not only for our physical therapists, but also for our nursing colleagues. So that took some education and understanding and assessment, so that can also be captured through our EMR. For medications, we picked very high-risk medications for our older adults, and that can also be captured through our EMR to our dashboard. And the last is that we're working on is identifying caregivers and language. Next slide.
I do want to just add to this. In order to do this at a system level, we needed to have the CEO, the leadership buy-in, and support to have everybody working on this, and to make it as easy as possible that this is all EHR driven metrics we're able to capture.
As you can see, this is Glen Cove Hospital and Forest Hills Hospital, my hospital, and we wanted to use pilot hospitals that were really engaged, and to be able to implement and prove that these metrics are making a difference. So this is a very pretty dashboard, and as you can see, we have incorporated our metrics. This is for what matters most, our goals of care conversations. And when we looked at our data, we also wanted to put in other quality metrics and how that interplays and is affected. That includes where the goals of care discussion is being had, like the emergency room versus the inpatient on the floors, the timing as soon as they hit our ED, by the hour, and also how is it impacting length of stay, readmission, the breakdown of the age group, and also incorporating the LACE score, which is a composite standardized nationally recognized score for risk of readmission, and also where they are landing when they're discharge disposition. So using those metrics and understanding how it affects our patient population is really important, but also looking at diversity and language. And as you can see, this is another dashboard of ours, and identifying not only our communities and patients, but also our workforce. So on the very top is all of our hospitals and our employee language proficiency. So you can see how diverse our workforce is, and how we are really reflecting the patients that we serve, and also the community that we serve. So that's the breakdown from workforce, patient population, and also the community.
Dr. Park works in Forest Hills Hospital, which has the most diverse employee population as well as the most diverse patient population.
Thank you. Next slide. So as we are incorporating and really enhancing our older adult care, and for the 4 M's, we have to really understand what our social barriers are to the 4 M's. No matter how perfectly we're performing that, if we're not ensuring access to care, including follow-up appointments, and also identifying if they're homebound, it's not going to help. Are we communicating with our patients well and being mindful of the language and culture, and using interpreters as much as we can, or maybe even having our workforce being able to communicate and identify. It means so much more when someone who speaks Spanish can identify with their culture and really understand the nuances of what those quality goals of care could be. Education is really important. So not only adhering to the treatment plan and understanding what it is, we have to account for literacy, and to also use a really great tool that we're not using often enough as our nursing colleagues is TeachBack. That can really ensure and enhance education. And always, and I put it in very big, include our caregivers. they're really, as you become older, and if there are caregivers, please utilize them and understand that they're really important part of the patient's life.
I will add that if you have care needs and you don't have a caregiver, caregivers are a social determinant of health if you have care needs. Caregivers, having or not having one, is a social determinant of health. They will help with access to health care, transportation, ability to get food. So just keep that in mind. So in summary, please be aware of ageism and other disparities as we age. Avoid making assumptions. Ask about a baseline function of a person. Don't make assumptions. Be person-centered, evidence-based. Be age-friendly. Use a 4M framework to understand what matters most to person in the language that they prefer. Medications, mentation, mobility. Identify caregivers and language of choice. Develop a care plan in the language of choice and with decision makers and caregivers aligned with what matters most. Can't say that enough. And measure age-friendly quality metrics. Thank you. Happy to take questions.
Yes, hi, this is Christian. I thought it was wonderful. Thank you. Y'all did an amazing amount of work. That was so, so intricate and very much appreciated. Keep it up. But I had a question. Some of the big discussion now about ageism that's going on in Capitol Hill is talk about, the president and is he too old to serve? Talking about Dianne Feinstein, and she's not been in the Senate because of shingles recently. So what is your all's take on that? And how do you respond to those? I mean, as a geriatricians, I think we probably have a different response, but I think, there's some age categories for like Senate and House, and I don't know. What is your thought about this discussion of age and public service?
So I'd be happy to take that. We have to be patient-centered, person-centered. It's not a number. There's such role models out there. We are living in a time that people are living longer and better than ever before. We really have to look at abilities, cognitive, functional, decision-making. So it really should not be about the number. It should be about the person and the issues at hand. So if you want to use an example of Dianne Feinstein, I think there are concerns because she's missing work. She's been missing work. So it's maybe her ability to work that should be discussed, not necessarily her age.
Age, right. Because we have like 50-year-olds, right, that can't hardly function. So, it doesn't,
Right.
It's all about functional status. So I just wonder if, we talk about op-eds, Maria, so, if the AGS or if anybody's put out position statements about this, because it's a great opportunity to discuss ageism, right? I mean, right now, that's what's happening.
Let's go for it, Christian. Let's write an op-ed piece. There is a lot of discussion, but, there's a lot to celebrate too. Look at,
I mean,
I think it's also eye-opening that we all have to plan to live till a longer time, and who's going to help advocate for us?
Yeah.
Dr. Park is a good advocate, and she's been an advocate for her family members, but we have to kind of plan for that ourselves.
Right.
Sometimes when there are really good caregivers, I thank them. I tell them, like, I am so glad that you're here for your mom or for your aunt, like a distant relative, because not many people have someone like you. And I thank them for the ones who are present.
Yeah, I think that's powerful because, and I was doing home visits, I would always thank them, no matter what they're doing, it's as good as they can do, right? If it's not perfect, I think everybody wants to be perfect. But today, I think Biden at 2:00 is going to have put out an executive order about improving care for older adults, caregivers, and child caregivers. Because, like, if you be able to provide child care, then the older adult can go to work and vice, so child care. So anyway, it's perfect timing because I think this is hot off the press today at 2:00.
Yeah, I saw.
Oh, Maria, I think you just went on mute. But did you all have what?
Can you hear me?
Yes, yeah.
I was just going to say that this caregiving is largely familial in this country. It's dependent on families. But this is affecting workforce and productivity. We saw it with COVID. People had to stop working to take care of both children and their parents. And this is a societal issue, not just a family issue.
It's economic, right? It's hitting people in their pocketbooks, and maybe that will make a difference. So did you have any pushback from your health system about this age friendly? Just trying to think about it. We've gotten somewhat successful in our health system, but not as big of an impact as you all have. So
I think our impact has largely been because our CEO has embraced this. If our CEO did not, I would not have been able to push this as far as we have. So a big point, and that was on Dr. Park's slide, is getting at the system level buy-in to say, create awareness, show why this is important, that this is all evidence-based, and it's a quality initiative that's going to improve quality efforts. And if we don't, then we're wasting our time. This is really to improve care and improve everybody. And it's evidence-based, so it should. And then at the hospital level, our first step we do is to go to the hospital and say, this is what we've done, this is why we're doing it, this is evidence-based, and Michael Dowling wants us to do this. Our Chief Medical Officer, Jill Kalman, wants us to do this. And we say, we don't want to waste your time. We want to make sure that this improves quality. And so far it is showing some benefit. We've had some best practices that have come out of that hospitals are having their quality improvement meetings around the 4 M's. So it's mainstreaming it. It's not just people are realizing this is person-centered care. And we use the analogy of cutouts in the sidewalk at the curb that were built for disability reasons, but it benefits everybody. It benefits the mother pushing a stroller, the tourist with a suitcase. Those cutouts help everybody. This is going to help everybody. And hopefully we're going to continue to show improvement. But it's been remarkable, the embrace.
do you know why the CEO was such a big supporter, or why the CEO embraced it? Was it like I don't know, sometimes there's a personal story, or did you hear anything about?
I think he was very respects IHI, the organization.
Oh, right.
And when we first started the whole Advanced Illness Collaborative, there was a big focus on goals of care and really trying to communicate better with our patients. And we've shown a lot of great data and cost savings. So that also speaks volumes. So I think from early on, the Division of Geriatrics and Palliative was very much embedded in working with the health system on a lot of quality improvement efforts, and that showed dollar savings too. So that was really helpful. And there was a lot of quality metrics that was tied into it. And I think that really showed, and it's been systematic, one best practice after another, especially for co-management in surgical patients for older adults. That was also really powerful and impactful. And that was another way to show how goals of care discussions really aligning care and cutting costs. I think Michael Dowling loves to be efficient, to be safe, to be enhancing patient experience, and really following standards and evidence-based and showing great data. Data really does move mountains, I believe. And if you can show it in a nice, beautiful way, and I think that's what was really helpful to work with the IT team as well. And I think that's why we were able to show that, we can't just throw out an idea. We got to really prove it.
Wow, it's a remarkable work. I don't want to take all the questions. I don't know, Hannah, did you say there's any other questions?
There are not any questions in the chat yet, but I have something I'd like to say. When you all mentioned that we are really focused on like healthy people, where like the infrastructure is really focused on like healthy centered. We don't consider like people with disabilities. We aren't very age friendly in the way things are set up. And I'm just curious what you think the first step would be in terms of infrastructure, kind of enabling people to go out and live their life when they aren't as mobile as they were before.
Really good question. When I was saying that, I was saying, you know, if you see a patient that's hospitalized that may have dementia, they're hospitalized and they're being treated for the UTI, the urosepsis, the aspiration pneumonia. We're so focused on the acute illness in a hospital, but there's often these chronic disabilities that we just put to the side, right? So the person who has an aspiration pneumonia, the big elephant in the room is their dementia, but we don't ever even see it on the problem list. We're dealing with the pneumonia. So it's like the system has been built for acute illnesses. So we need to start just creating awareness and highlighting and talking with families as well who are caring that, okay, yes, we're treating the urosepsis. Yes, we're treating this aspiration pneumonia. But based on what you're telling me how this person was 6 months ago, they have advanced dementia. Can we talk about that? You know, so I think it's being whole person, not just disease focused. And that's what the 4M framework is trying to do for the health system, is be whole person as opposed to disease.
And the other thing is, just like Dr. Carney is saying, is understanding the environment that they're living in and what that transition to home is going to look like. And like I mentioned before, we're so used to just acute care within the walls of any institution, either, you know, in a hospital setting. We don't think about when they go home, what can we think about and what resources do they need to really enhance their recovery, continuing recovery. So Dr. Carney oversees continuum care. I focus on a lot of transitions care with the hospital, and I teach my team, my geriatric palliative care team, talk about what going home is going to look like. What can we do to enhance their recovery? And maybe not get back to their baseline, but at least trying to get back to as much of their baseline as possible, because it could be a new baseline. And that also requires a lot of education with the caregivers and the patient, and setting expectations, realistic expectations.
Yeah, I think we create a lot of care plans for people that fail because we're not looking what is capable to be implemented at home and what the realistic goals are versus, so it's goals of the patient and goals for the family to achieve those goals.
I never realized how prevalent ageism was in so many aspects of our like daily life, like the phrases you use, like having a senior moment. I hear that.
I'm guilty of it.
My 45-year-old husband says, I think I have early dementia. I was like, no, that's called selective memory.
Like, calm down. I didn't realize just how prevalent it was.
Yeah, I love your example about the commercial too, that, you know, that's really a popular commercial, but right, it's ageist.
I mean, it is funny. I do want to give them credit. They are clever, but
Yeah,
I know my children are like, oh my God, that's you, Mom.
On our first panel today, we talked about, like, if you see something, say something. So they said, like, just you all calling it out as ageist really helps, because then now that, you know, we can all call it out when we see it and say, hey, listen, my kids they're so funny. They've started, because I mean, you know, like, even saying the word elderly, it's not really politically correct. I mean, it's not the best term. It's not encompassing, and it leads to more division. You know, older adult is the best term. So my kids are always going around correcting, because I correct people. I mean, I just can't stand it when people say it. And so I see my kids do it now. So I guess, yes. We can change things one by one. Well, all over DC, the subways. It says elderly all over the place. So yeah, we'll have to pass a law to get that changed.
I know. But yet the term elder is respectful.
Yes,
Right?
it's so
Well,
interesting.
your elder, it's not,
It's
you know,
not
yeah, but describing somebody elderly,
they don't want to. They don't want to be called. A lot of older adults don't want to be called elderly, right? Because it kind of gives that frail connotation to it. You know, who knows? It's so complicated.
no. But maybe at 90, I'll be running a marathon, so that'll show them.
Water skiing, you know.
Yeah.
We have a panel later with all these older adults, so they're doing amazing things. It's pretty cool.
Well, Dolly Parton's a very good example of still kicking it.
How old is she? 80 something, right? Or is she 90?
I don't know.
She's
no,
ageless.
she's almost getting ready to turn 80. Maybe she just did turn 80. Yes, I did hear
She's
that.
ageless. Now I have to Google how old she is.
It's amazing. Well,
Thank
thank you so much.
It was a great presentation. I learned so much detail. Yeah, we'll have to bring some of this back to our health system. So,
All right. Any way we can help, you let us know. Thank
Sure.
you.
Have a good day.
Thank you
Bye.
all for joining us today for breakout session number 4, Age-Friendly Health System Implementation. I would like to remind you that we appreciate your feedback, and this session is eligible for continuing education credits. Please complete the evaluation for this session contained in the email you received this morning with the subject line OAC 2023 Post-Session Evaluation link. Thank you and have a great day.